Yes, sir.
Good afternoon, everyone. Happy to see you all. I am this Simpson George, OATN General Secretary, and I am practicing in consultant optometrist in Gramaltas Hospital, consultant optometrist in Kalanjar Eye Clinic, and proprietor of IQ Eye Clinic, Chennai. Am I audible?
Yes, sir.
Yes, sir.
Okay. I'm so excited about today. All are so energetic, even though in the so much of sunny. Am I audible to everyone?
Yes, sir.
Yeah. I welcome our guest. There are two judges out there. First judge, I would like to intro Optum Ambika Chandrasekhar. And hello, ma'am.
Hi, Simpson. How are you?
I'm doing good. What about you?
I'm well. I'm doing well.
Yeah.
Thank you.
Okay, ma'am. So I would like to intro about Ambika Chandrasekhar, ma'am. She is an optometrist and academic background from the elite school of optometry, where she has completed both her graduated UG and PG, and she is leads a team of profession at ESO, including optometrists, optometry students, social workers, and supporting staffs. And academic and professional roles, assistant professor of ESO, and teachers, undergraduate and postgraduate, sharing her expert with this new generation of optometry. Her leadership and teaching role are completely by research and interest, and primarily focus on public health and quality of vision. And researchers in vernal keratoconjunctivitis, myopia, ocular condition, and among the school children. And second judge, Ms. Chitra, ma'am. Good afternoon, ma'am.
Hi, good afternoon, Simpson and Ambika. I hope both of you are doing good.
Hi, ma'am.
Yes, ma'am.
Hi.
Happy to see you, ma'am.
Thank you.
And ma'am is professional and strong academic foundation, holds BS and MPhil in optometry and essential and from the esteemed elite school of optometry, Shankara Nethralaya, with over 17 years of experience and clinical appliances, academic and research. She has esteemed as a leader in her field. And her achievement and clinical appliance management, academic leadership, mentorship, research, and publication. And she is specialized in contact lens and vision therapy. And ma'am holds key and including assistant professor, vice principal, and optometry in charge clinical appliance management. And she is educated in faculty, and she is a specialized in low vision therapy, and a specialist in contact lens also. Thank you, ma'am. Welcome you both. Thank you for the showing interest in OATN. Keep supporting us.
Definitely. Thank you so much. And best wishes to all the participants over here.
Okay,
Thank you,
ma'am.
Simpson, for a kind introduction of me. And it's very fortunate that I'm here. Thank you so much for the opportunity. And all the best for everybody who are going to participate today's session.
Okay, thank you, ma'am. So each person will have to take 6 minutes and 2 minutes for question session from judges. And first, I would like to call our Tamil Selvi and case number U42. Once she has finished, next one can share the slides so we can save our time. Followed by Tamil Selvi, Sharon M. U48. Be ready on time. Yes, Tamil Selvi, can you speak?
Yes, sir. Good afternoon, all. I'm Tamichelvi doing Optom internship in Dr. Agba Institute of Optometry, Tirunelveli. My case report is about choroiditis along with CSAR and retinoscheitis. Central serous chorioretinopathy is a chorioretinal disorder that is characterized by accumulation of fluid between neurosensory retina and RPA layer, and the rare manifestation of subretinal fiber deposition. Retinoscheisis is nothing but splitting of intraretinal layer commonly leads to retinal detachment, which breaks the retinal outer layer. RD is common in intratemporal quadrant of schisis, localized in retinal detachment, occurs in approx 9% of retinoscheisis patient. The association of systemic diseases like TB can also lead to choroiditis, where the detachment have been breaks in outer and inner layer. Eventually, vitreous humor enter the schisis cavity and to the subretinal space. This case report presented 50 years male, a businessman with complaints of itching in left eye for past 2 days and blurring of vision in both eye for past 5 days. The patient has history of ocular trauma and not under any treatment and follow-up. Patient done YAC-PA 1 year back in both eye and retinal laser done 6 year back. Patient using spectacle for more than a year. Last change 1 year back. No history of systemic medication, allergic and family history. The visual acuity in right eye was 6/24 partial with pinhole improved to 6/12 pass. In left eye, the visual acuity was 5/60 with no improvement with pinhole. Patient did 6/24 in both eye. Near visual uncorrected visual acuity in right eye, left eye and both eye was N60. The previous class prescription of the patient in right eye was plus 0.50 dioptric sphere plus 1.50 dioptric cylinder at 180 axis. Patient did 6/12 partial. In left eye, patient did accept the power. The best corrected visual acuity remains same as present class prescription. The near at plus 2 dioptric sphere patient, it's N10 in right eye, N60 in left eye, and N18 in both eye at 30 centimeter. The Ishihara test was revealed mild red desaturation in both eye. I perform as confrontation, right eye remains normal, but in left eye, the field of view is constricted. Based on confrontation result, further investigation with Amsler grid chart result constriction of visual field in left eye. Slit lamp examination revealed normal PA patent in iris at 10 o'clock position in right eye and 4 o'clock position in left eye. Fundus shows 0.2 cup disc ratio. Absent of fundus reflects pigment alteration and retina attached with pigment atrophic changes in posterior pole. Choroiditis with inferior shallow subretinal fluid and chronic multiple CSCR in both eye. Additionally, with retinoscheisis and subretinal fibrosis in left eye. Further, we investigated with FFA, OCT, fundus photo, and laboratory investigation. Here, the fundus picture shows a multiple pigment alteration at fovea and both eye. FFA findings shows increased disc staining noted in later phase. The line-adjusted OCT protocol reveals the accumulation of subretinal fluid in both eye and the presence of macular edema break in inner and outer retinal layer in left eye. The OCT macular Q protocol reveals a cystic space altered ISOA junction in left eye. The lab investigation CBC, ESR, CRP, ACE, PDRL, and RFT shows negative, and mantle shows positive. Based on the findings, it was diagnosed as chronic CSER and compound hypermetropic astigmatism in left eye and multifocal choroiditis along with CSER and retinoschisis. This was managed with intraretinal injection, acentric, Razumab under guarded visual prognosis, and referred to pulmonologists for further TB management and advised to regular follow-up. The patient is treating with the medication of Zenzolol, eye drops, Brinzox, Aconac, and Refreshes. Coming to the discussion part, the Nguyen et al. Says that multifocal CSCR can be mimicked as Vogt-Koyanagi-Harada disease with pre-assumption disease of VKH can be treated with corticosteroid that can result to macula-involved RD and retinoschisis. Choroiditis along with CSER and retinoschisis should be treated timely to prevent complication. Multidisciplinary approaches can potentially manage, especially it was associated with systemic disease like tuberculosis. These are my references. I acknowledge to my professors. Thank you.
Thank you. Thanks so much. And best wishes for your case presentation.
Thank you. Sir.
Judges, yes.
Ma'am, you want to go first or I'll take the question?
1 second. Yeah, you take it first. Maybe the next I'll follow.
Okay. Very nice presentation, Tamil Selvi. Congratulations to you. I read your case report. Good. Requires a little bit of improvement in that. Let me ask you one question. You said that the Mantox test showed the positive results. What do you think you need to run any other test to confirm before looking for a clinical correlation with tuberculosis? What is the gold standard test that you do to say the person has tuberculosis?
Yes, Tamis.
X-rays like X-ray and CT scan.
X-ray and
CT scans.
okay. Ma'am, if you have question, you can take up. Thank you, Tamil
Yeah.
Selvi.
Tamar, I would just like to know, like, did you had any chances of measuring the macular edema pre and post management, or like how much it was reduced, and how about the vision? Did you had any chances to have a follow-up of that? Because the macular edema was so much, and even the fluid collection is very high. And the vision is also 5 and 16, right?
Follow up regularly, ma'am.
Okay. Okay. Thank you.
Thank you.
Thank you.
Thank you so much, Tamil Selvi. Next participant, Saran. Can you
Next
share
one
your
will
slide?
present from this device, sir.
Same, okay. Case number U48. So Saran, are we there? Yes, participants, Bangaru is available. Be ready for next one. Saran, can you hear me?
Respond பண்ணலன்னா we'll move on to the next person.
Okay,
அதுக்கப்புறம் we'll get
fine. Okay. Bangaru YS. Case number 4 U49.
Yes, I am here, sir.
Yes. May I know your name?
Bangaru
Saran
IS.
or- Bangaru, yeah. Please go ahead with your slide. Next one, Ramalakshmi, be ready with your slides.
Sorry to interrupt. Bangaru is like, what is the number? Case ID?
Case ID U49, ma'am.
49. Okay, thank you.
Yes, yes. Okay. Yes, please go ahead. Your time starts. Bangaru, you can unmute and speak.
Am I audible, sir?
Yeah, now it's audible. Please go ahead.
Is my screen visible, sir?
Yes.
Good afternoon to everyone present here. This is Bangaru. I'm here to talk about missed pre-operative angle closure in cataract and vitrectomy surgery diagnostic pitfall. Introduction. Angle closure glaucoma is a potentially sight-threatening condition characterized by the blockage of the trabecular meshwork leading to increased intraocular pressure. Undiagnosed angle closure is particularly concerning in context of surgery as a pre-operative period can exacerbate underlying ocular condition leading to post-operative complication. This case reports highlights an undiagnosed angle closure in patient undergoing routine ocular surgery which leads to post-operative complication. Through this case, we aim to emphasize the importance of comprehensive preoperative ocular assessment and the potential risk of overlooking angle closure glaucoma in surgical candidates. Case history. A 57 years old woman came with a complaint of pain, watering associated with photophobia since 3 days. 13 days back, she had a cataract surgery and plasmapherectomy with gas in right eye, no systemic illness. Patient was under topical steroid and antibiotics. Clinical examination and unaided vision in right eye is 6 by 12 and N10 cornea was clear, AC was shallow. Intraocular pressure in right eye is 14 mmHg. Unaided vision in left eye is 1 by 6 NAS. Corneal edema, dilated pupil, intraocular pressure is 60 mmHg. Gonioscopic finding in right eye is angle closure. In left eye is narrow angle configuration. Trabecular meshwork seen in 2 quadrants. Patient has been diagnosed as angle closure glaucoma. IV mannitol given on the same day, followed by YAG-PA. After 3 days, patient had 24 shots in right eye and 16 shots in left eye. First review after YAG-PA, patient vision has been increased from 1 by 60 to 2 by 60 in left eye. Corneal epithelial roughening in right eye. Anterior chamber deep in both the eye. PA pattern in both the eye. Second review, patient came for YAG PI review. Unaided vision in right eye is 6 by 9, left eye is 4 by 60. AT values in right eye is 15 mmHg, left eye is 10 mmHg. Patient has been prescribed Rotos 4 times a day and PET 4 times a day for 2 weeks. Third review, patient was prescribed high drops. Unaided vision in right eye is 6 by 9, left eye is 5 by 60. Intraocular pressure in right eye is 16 mmHg and left eye is 10 mmHg. Microcystic edema seen in right eye. In right eye, NS2, left eye is PCIOL. Fundus was normal in right eye. view was haze in left eye. Patient has been prescribed pet food 6 times and door toss 2 times a day until next visit. Fourth review, unaided vision in right eye is 6/9, left eye is 2/60. Intraocular pressure in right eye is 15 mmHg, left eye 0.0 mmHg. Slit lamp finding corneal decomposition in left eye. Refraction in right eye is plano, and the vision was 6/9, left eye +2, and the vision was 6/60. Slit lamp finding gas bubble and peripheral choroidal detachment in left eye. Patient has been advised to use tablet Bison and tablet Pan 40 for 7 days. Patient advised to get opinion from retina specialist. Advised to take B scan, and B scan report shows retina detachment seen in inferior and superior. Retina is attached in macula and disc. Choroidal fold seen, but optic nerve head shows seen normal. Patient came for retinal surgery in opinion after 1 month. Unaided vision in right eye is 6/9, left eye is 2/60. Refraction in right eye is plano, and the vision was 6/9, left eye +4 spear and +1 cell in 260°, and the vision was 6/9. Slit lamp finding in right eye is NS2, and the left eye is corneal decomposition improved. Slit lamp finding retinal decomposition inferior quadrant macula of OS. Advised plasmana vitrectomy with N plus endolaser plus membrane peeling plus silicone oil infusion under local anesthesia. Conclusion, the patient underwent cataract surgery at the previous hospital without prior assessment of intraocular pressure and gonioscopic examination, which leads to complication. Post-operatively, the patient developed a significant increase in intraocular pressure reaching 60 mmHg and was consequently diagnosed with angle closure glaucoma in the left eye. This case highlights an importance of thorough preoperative evaluation, including IOP measurement and gonioscopy, to identify potential risk and prevent everlasting complication. As an optometry, I must it is as an optometrist, it is crucial to assess and preoperative assessment for every patient. Acknowledgement, Dr. M.V. Veenastri and Kalaivanan Hariharan Optum. I also thank the faculty at Vasan Institute of Ophthalmology and Research. Finally, I could like to express my gratitude to OATN for giving this opportunity to present this case. Thank you.
Thank you.
Thanks,
Thank you so
Bangaru.
much, Magaru.
Yeah, definitely it was a very nice case, like where the proper follow-up and review has been done, and it stresses on the importance of taking the intraocular pressure as well as an optometrist. Very neatly presented. One question is there any associated systemic diseases for this angle closure glaucoma? Like, it has been checked for that patient as well?
No, ma'am, she had no
No other any specific
systemic illness. Yes,
diseases
ma'am.
causing this angle closure glaucoma?
No,
Right?
she didn't know. She didn't have any systemic illness, ma'am.
Okay. Okay. Thank you.
Okay.
It was nicely presented, Ms. Bangaru.
Oh,
I
thank you.
am very confident in presenting as well. So
Thank you, ma'am.
I have a bit doubt. I don't know. In my understanding, post cataract surgery, usually the AC depth, it typically increases, reducing the risk of the
Yes,
primary
ma'am.
angle closure glaucoma.
Mm.
Do you think we need any more assessment to confirm that this is
Ma'am,
actually the
I
angle closure
can't hear
glaucoma?
your voice, ma'am. I can't hear your voice properly, ma'am.
Can
Your
I think
voice
so.
is breaking, ma'am.
Yes, ma'am.
now? But I can hear you all well. Is it still
Yes.
not clear?
Now it's fine.
No, it's fine. Okay,
Yes.
so I'll just break down my sentence. So what I usually think the AC depth usually increases after the cataract surgery. So
Yes,
if it's like a regular angle closure suspect or glaucoma, it should actually help, But what do you think could be the other tests should have been done? Or I also, need what? How did you confirm that all the pre-operative tests were not performed in the previous hospital? Did the patient had the all the details with the patient as a
no, ma'am.
report? Like how did you, you know, saying that the patients did not underwent all the pre-operative tests in the previous hospital?
In previous hospital, they didn't check intraocular pressure and gonioscopy, ma'am, in pre-operative period.
So you had all the
Yeah, no, ma'am.
documents.
There was no report, ma'am.
So other than IOP, other information, other test results were there with the patient.
No, ma'am. She didn't know anything. We found out everything, ma'am.
Okay, so I could also, suggest that there could be other reasons, just because of the cataract surgery. Also, they could, develop glaucoma because of the placement of the IOL and everything. Or it could be, we can also check for the pigments of the angle, whether that is what causing the angle closure. So probably we can, do a little more of tests. Again, egg scan would have been
Yes,
done
ma'am.
to look at.
And she had RD and correlated detachment at both the time she had that. So we gave Vislon tablet to that patient, but Vislon tablet is only for correlated detachment, not for RD. So we said the patient to do vitrectomy. So the patient is not willing to do it, ma'am.
Okay, so I don't want to take up so much time. I also have a lot of questions. I have already read your case report. I have all the questions in mind. Probably I can give it to you at the end.
Okay, ma'am. Thank you, ma'am.
Thank you.
Yes.
Nice, well
Thank
presented.
you, Bangaru.
Thank you, sir.
Yes, next is, yeah. Ramalakshmi, can you share your slides? After this, Kamalika, be ready for next.
Sir,
Ramalakshmi, please go
Charan
ahead.
and Dam Lakshmi will be presenting the case from this device, sir.
Okay.
Okay.
Okay. Please go ahead. Case number U50, Ramalakshmi.
My case report about central serous polioretinopathy. CSCR is also known as CSCR.
Ramalakshmi, can you?
With the retinal condition that affects the posterior segment. Is localized to the
Now, who is presenting? Sorry. It's U40 it is
Ramalakshmi.
being seen.
Ramalakshmi.
Charan.
Charan,
Sharan is there. Yeah. It's U48, I believe, right?
Yes, U48.
Okay. Thank you.
My case report is about central serous polioretinopathy.
Sharan, your voice is very low. Can you speak louder or keep it closer?
Okay, sir. CSCR is also known as CSR, which is the retinal condition that affects the posterior segment. It is localized by the serous detachment of the neurosensory retina, along with the abnormalities in the retinal pigmental epithelium. Visual disturbance mostly arises from the serous detachment, located in the macular central region. Treatment for CSCR includes photodynamic therapy and various laser treatment work depending on the severity. This case represents 35 years old male who is an IT worker present with a complaint of blurring of vision for distance and pain in right eye for past 3 days. Patient using spectacles for past 3 years and changed 1 year back. Patient had vital sign of high pressure and inadequate sleep, no systemic and no allergic history. Uncorrected visual acuity in both eye was 6/36 with pinhole, 6/6 and near visual acuity. The previous last prescription in right eye was -2 CI -1 in 180 axis. Patient rated 6/6 parts in left eye -2 sphere -1 cylinder 180 axis. Patient rated 6/6 parts. The best corrected visual acuity in both eye -2 sphere -1 cylinder 180 axis. Patient rated 6/6 in both eye and near visual acuity in 10/6 at 35 cm. The color vision and concentration remains normal. But after it shows the right eye and abnormal in left eye. Slicular examination reveals appearance, appendage, conjunctiva, sclera, cornea, AC, pupil, iris, lens, and ocular motility. But the fundus right eye shows action foveal reflex with the CSER. The OCT macular cube scan protocol shows subretinal fluid accumulation between the RP and neurosensory retina. Management includes Navanek eye drops 4 times a day for 1 month in right eye, Dorsax eye drops 2 times a day in right eye, Alprex tablet in 1 time a day for 1 week only at night. Patient advice with the lifestyle modification and to avoid stress, regular and 8 hours sleep. Avoid computer usage and to follow 2020 X. Coming to the discussion. What this case highlights blurred vision and ocular pain. With the OCT image and slit lamp finding that suggests a central serous Fourier anomaly, subretinal fluid accumulation. This can be associated with the irregular sleep pattern and work-related stress. With the proper medication and lifestyle modification can change manage CSCR. This case concludes part of CSCR after young males work-related stress. This can be associated with CSCR onset. This case suggested with the blurred vision and pain and significant subretinal fluid accumulation confirmed CSCR is managed with the proper sleep and stress management strategy and prevent recurrence. This also suggests a continued follow-up and various management strategy. These are my reference.
Thank you, Saran.
Thank you. Thank you, sir.
Shall I go ahead, ma'am?
Yeah, please.
It's a nice presentation, Saran. I have a simple question. How do you think the work-related stress can be reduced? Because in work, there's going to be always stress, and we cannot also ask the patient, please don't work. So how do you propose to, how do you, counsel the patient when the patient is suffering from such a conflicting management? Hello?
Frequent breaks and lifestyle modification.
Do you think that would reduce the work-related stress? What kind of breaks you are talking about? Okay, maybe there's one more question. I just quickly ask this, probably no, for your future reference. So, or I can give you the answer itself. So we have a validated questionnaire available to understand about the work-related stress. So it is known that at work you will definitely face stress. So whether it is affecting you or not. So there are two part of questionnaire. Probably I can share it with the OATN team. Probably they can share it with you. So you can also assess the amount of work stress that the person going through using such questionnaires. Okay, so that could also help you supporting your diagnosis and treatment management and everything. Thank you, ma'am. Please go ahead.
Okay,
Yeah.
thank you.
Even I was wondering the same thing. What kind of lifestyle changes that he counsel the patient to improve? So anyway, maybe I got the answer from Abhiga herself. Like she's going to give the questionnaire. That was a nice presentation. Okay, that's it. I'm happy with that.
And my curiosity,
Thank you.
ma'am, I want to ask
Thank you,
one
ma'am.
question to Saran.
Yes, sir.
Yeah, so what was the CFT for this patient in OD?
Mhm.
Central foveal
Sir, I cannot
thickness.
hear.
Central foveal thickness in OD.
Fluid accumulation.
Sorry?
Fluid accumulate.
Yeah. Fluid accumulate, I can understand. I'm asking central foveal thickness in OCT. 434. Am I right?
Sir.
Yeah. And the vision in right eye? 636 with pinhole 66. Am I
Yes,
right?
sir. Yes, sir.
If in case a CFT3 for 434 is there, where the vision is 636 with pinhole will be around 612 only, because that central foveal thickness is 400 microns nearly. Okay, the pinhole will not improve up to 66 definitely. That's my doubt. You have to check the vision with pinhole correctly. Okay. Okay, Sharon. Thank you.
Okay.
Can go for next presentation. Ramalakshmi. Can you share your slides? Ramalakshmi, case number
Yes, sir.
U50.
Yes, sir.
Yeah, please go ahead.
One minute, sir.
Yeah. And followed by Ramalakshmi, Kamalika. Be ready.
Shall I start, sir?
Yeah, please go ahead.
Good afternoon, all. I am Rama Lakshmi, doing B Optom finally in Dr. Raghunathan Institute of Optometry, Telangana. My case report is about proliferative diabetic retinopathy with fractional retinal detachment. Proliferative diabetic retinopathy is associated with metabolic disorder along with diabetic type 1 and type 2. If proliferative diabetic retinopathy left untreated, they can lead to severe complication includes neovascular glaucoma, fractional retinal detachment, vitreous hemorrhages, and diabetic macular edema. A condition like retinal detachment can occur when neosensory retina with phototransited with separate underlying retinal pigmented epithelium. Basically, retinal detachment can be divided into fractional retinal detachment, exudative retinal detachment. Fractional retinal detachment can occur with severe stage of diabetic retinopathy, but involving macula and non-involving macula. Fractional retinal detachment being managed by systemic and ocular management. That includes controlling of diabetic mellitus, hypertension, hemoglobin fatigue. Ocular management includes anti-vascular endothelial growth factor agents, pan-retinal photocoagulation, vitrectomy. My case report is with 66 years male painter presented with a cheap complaint of diminution of distance vision in both eyes for past 1 year. Patient undergoes retina laser in right eye 1 year back. Systemic history includes diabetic mellitus for past 10 years under treatment with unknown medication and hypertension for past 5 years with unknown medication. DM was not under control. There is no relevant of allergy history, family history, and social history. The uncorrected visual acuity in right eye was 4/60, and there is no improvement with pinhole. In left eye, patient read 6/36 with the improvement with pinhole 6/24 partial. The near vision add plus 2.50 dioptric speed, patient read N24 in left eye, but no improvement and unable to read in right eye at 30 centimeter. The color vision shows red-green defect in right eye, abnormal visual field in both confrontation test and Amsler grid chart. Slit lamp examination reveals normal appearance, eyelid eyelets, lacrimal apparatus, conjunctiva, sclera, cornea,
anterior chamber, iris, pupil in both eyes. Neurosclerosis grade 3 was diagnosed in right eye, and neurosclerosis grade 2 is diagnosed in left eye. Fundus shows hemorrhage, microaneurysm, or exudate. The foveal reflex is dull, retina attached with tractional retinal detachment and fibrovascular proliferation in supraretinal quadrant in both eye. In right eye, with inferior vitreous hemorrhage and pan-retinal photocoagulation scar noted. In left eye, inferior vitreous hemorrhage is noted. Further, we investigated with fundus photo, OCT, macula, radial scan, and laboratory investigation. The fundus picture shows presence of hemorrhages, microaneurysm, hard exudates, and tractional retinal detachment. The past pan-retinal photocoagulation scar was marked, we can see. In OCT macula radial scan shows presence of subretinal fluid in between neurosensory retina and retinal pigmented epithelium layers. Tractional and macular thinning we can able to see. OCT macula in left eye presence with cystic space with break of inner retinal layer. Laboratory investigation reveals abnormal lipid profile. Based on this finding, the patient was diagnosed with age-related nuclear cataract in both eye, proliferative diabetic retinopathy with tractional retinal detachment in both eye. Patient was advised with phacoemulsification with foldable intraocular lens implant in right eye with anti-VEGF injection under GDP, vitrectomy in right eye under GDP after 3 days of anti-VEGF injection. Retina laser photocoagulation in left eye 5 sitting under GDP. Patient was advised with strict diabetic control. Prognosis of vision explained to the patient. Patient was managed with Nepastar 1 time a day for 1 month in both eye. Coming to the discussion part, line J.B. et al. Found systemic health, diabetic hypertension can lead to ocular complication like proliferative diabetic retinopathy. Proliferative diabetic retinopathy can be treated with anti-VEGF injection and pan-retinal photocoagulation can help to reduce the risk of tractional retinal detachment. I conclude this case with systemic management can help to ocular complication. Comparing surgery and phacotherapies can help to prevent vision loss and complication. Monitor diabetic control and hypertension regularly can manage the ocular health. These are my reference. Thank you, my professor, for helping me during this case study. Thank you, OATN, for giving us this opportunity.
Thank you, Ram Lakshmi.
Yeah, thank you, Rama Lakshmi. I just have, it was very nice presentation there. Just wanted to understand from the optometrist's point of view, being a painter by occupation, you have mentioned there is red-green deficiency as well as the confrontation is abnormal. So did you suggest any aids for that, or did it really impact life of that patient, or the quality of that patient?
Ma'am?
Can you hear me?
Yes, ma'am.
Yeah, can you just go back to the slides, because it has been mentioned the patient was having a red-green deficiency and he is a painter by occupation, correct? And the
Yes, ma'am.
confrontation was also abnormal. So was it as quite manageable for that patient, or did you give any aids from the optometrist point of view, or that's just a query like.
By giving
Because
the
his vision is
patient,
also 4 by 60 and 6 by 24 in both eyes. which falls under the low vision
Ma'am,
category as well.
Yes, we
So,
have suggested with the patient with astromic lens, but the patient did not accept it to wear it.
okay. Okay. Thank you.
It's a nice presentation, Ramalakshmi. I have one question to you. What do you think an optometrist, where do you think an optometrist can play a role here for this case, this kind of conditions?
Ma'am, by giving the glass, we can help them, but the patient is not willing.
Do you think anywhere diagnosing or monitoring a condition where optometrists can play a role?
Yes, ma'am.
Yeah, we do have guidelines, referral guidelines for such retinal condition, especially for DR, published by Dr. Rajiv Raman. So he has given. I can put that paper in the chat box if you want. You can take it and read on it. So that can be used to diagnose. I mean, to understand the initial screening of diabetic retinopathy and when you can refer to where you can refer. All of that is given in detail in the paper. So I think it will be helpful for any optometrist in the forum today.
Okay.
Thank you, Ramalakshmi.
Okay, ma'am. Thank you, ma'am. Thank you so much, ma'am.
Thank you.
Thank you, sir.
Thank you. Next, Kamalika.
Yes, sir. I'm here.
Case number U51.
Yes, sir.
Yeah.
Shall I start, sir?
Yeah, please go ahead. Sahana, be ready. Next is yours.
Is my screen visible, sir?
Yeah.
Good afternoon to one and all present here. Firstly, I would like to wish you all a happy World Optometry Day. This is Kamalika. I'm here to talk about hereditary ectopia lentis, a case report of lens subluxation and surgical intervention. Introduction. Ectopia lentis refers to the displacement of crystalline lens due to weakened or disrupted zonular fibers. It can result from trauma, systematic diseases, etc. Hereditary ectopia lentis is associated with connective tissue diseases such as Marfan syndrome, Weil-Marcesani syndrome, and homocystinuria. It may also present as isolated familial ectopia lentis. This condition can lead to significant visual impairment due to progressive refractive errors and can also cause secondary complications such as glaucoma, retinal detachment, etc. In this case report, we present the patient and her daughter with hereditary ectopia lentis who underwent surgical intervention. We discuss the diagnostic approach, the challenges faced during the management, and the post-operative outcomes for this case. Case history. A 33-year-old female patient approached the ophthalmic clinic with a chief complaint of progressively worsening vision and increasing eye power in each visit over past few years, OU. There was no trauma or surgery or any systemic illness for the patient. Clinical examination on day 1. Her corrected visual acuity was 20 by 60 on OD and 20 by 30 on OS. Her best corrected visual acuity on OD was 20/30 and BCVA for OS is 20 by 30. Her refraction was -3 with -6 cylinders at 120 degree. For OS, -1 with -4 cylinders at 20 degree. While doing retinoscopy, there was no scissor reflex seen. Slit lamp examinations findings were deep anterior chamber with normal IOP, OU, lens subluxation, OD superior nasal, and OS superior temporal. The lens also showed mild phacodonosis, OU. Fundoscopic findings showed normal optic discs and retina with no signs of RD. Patient was advised for pentacam to rule out the corneal astigmatic power and to plan to evaluate on homocystinuria value. Investigation on day 2. The pentacam report shows that the cornea were actually flat and there was no keratoconus. Test for homocystinuria was also negative. On day 2, after all investigation, we diagnosed it as isolated ectopia lentis. For management, contact lens trial was given and toric contact lenses were prescribed and dispensed. For advice, the patient is advised for clear lens extraction, OD first, if subluxation progresses. After 6 months, patient reported with a complaint of flickering vision while driving and other activities. Hence, surgical intervention was planned. Her preoperative vision and refraction was her corrected visual acuity was 20 by 120 and the best corrected visual acuity was 20 by 30 in OD. Her corrected visual acuity is 20 by 60 and best corrected visual acuity was 20 by 30 in OS. Her refraction was -3.75 with 8 cylinders at 130 degree and -1 with -6 cylinders at 20 degree. Surgical procedure. Patient underwent clear lens extraction with capsular tension suture in the sulcus under local anesthesia on the worst eye, OD first. The surgery was uneventful with stable IOL fixation. Post-operatively, the patient was prescribed topical steroids and antibiotics. 4th-week follow-up. Her BCVA improved to 20/30 in the operated eye with the refraction from OD minus 3.75 with 8 cylinders at 130 to OD plano with minus 1.25 at 90 degree. Patient's IOP remained within normal limits. As the patient reported with significant visual improvement, surgery for the fellow eye was planned. After 2 months, patient accompanied with her 4-year-old daughter for eye checkup to check for familial presence of ectopia lentis. Her daughter's unaided vision on OD was 20/200, OS was 20/30. Her atropine flash showed minus 3 with minus 8.25 cylinder at 142 degree, and plano with minus 2.25 at 50 degree. After optometric workup done, she had undergone atropine dilatation. Slit lamp examination revealed OD superior nasal lens subluxation and OS superior temporal lens subluxation. OD was more than OS. Her PMT refraction was minus 3 with minus 6 cylinders at 140 degree in OD and OS plano with minus 1.50 at 50 degree. She was advised for occlusion for 6 hours OS. If subluxation progressed, planned to do clear lens extraction with capsular tension suture in sulcus under general anesthesia. RTC 2 weeks. As the vision progressively decreased in OD, first the surgery was planned. Patient's daughter underwent clear lens extraction with CTS under general anesthesia. Discussion. In our case, several important clinical considerations in diagnosing and managing hereditary ectopia lentis have been highlighted. The progressive astigmatism did not originate from cornea as the pentacam findings were normal. Hence, lenticular pathology was suspected. Dilated pupillary examination with slit lamp detected absence of zonules, reinforcing the need for close follow-up. Homocystinuria was also ruled out with laboratory testing, further supporting the diagnosis of isolated hereditary ectopia lentis. Conclusion. Our report highlights the importance of early recognition and individualized management strategies in hereditary ectopia lentis. The role of familial screening is also emphasized. As early diagnosis in affected relatives can prevent long-term visual impairment, surgical intervention with CTS-assisted clear lens extraction proved to be an effective approach in restoring vision and ensuring the long-term ocular stability in this patient. In performing my case study, I had to take the help from some respected persons who deserve my greatest gratitude. Hereby, I would like to acknowledge Dr. MP Veenashri Dhanvantri Aikar, Optoms K. Kalaivanan, J. Hariharan for their help towards the report, faculty of Vasan Institute of Ophthalmology and Research for their guidance. Finally, I'd like to express my gratitude to OATN for giving me this opportunity to present this case. Thank you.
Great job on your case presentation. Nice.
Thank you, sir.
Thank you, Kamalika. Thank you so much, for bringing out such an interesting and wonderful cases. All of you people, definitely. So, just a small question, were the patients, the parents were also given genetic counseling regarding this? Has that been done?
Actually, the patient given the genetic counseling, ma'am, her parents were also having some unknown vision problems, but they are not done any ophthalmology checkup. But we
because
counseled.
the risk is very much when you're having this hereditary ectopia lentis kinds of just
Yes,
wanted to
ma'am.
understand.
Yes, ma'am.
Okay, ma'am. Thank you.
Thank you, ma'am.
It's a very nice and confident presentation, Kamalika. It's a nice, interesting case as well. You also mentioned in the case report about her daughter also having a similar problem.
Yes.
A case series of or like a case story of a family, including all the details, would be more. I would expect more details on her daughter.
Yes, ma'am.
Case as well. But my question for you is probably a very simple question. How about how you go about doing refraction for patients who have subluxation of lens?
As a optometrist, we should also think that the thing with this case is the point I'm taking time to make is the cylinder power is not only because of the cornea. That is the main thing. As a refractionist, anyone should know. As an optometrist, anyone should know to give a proper refraction and also to know the diagnosis of what the patient has.
Okay. All right. I had the genetic question as well, ma'am has asked. And I also wondering what is the exact, indication to do a pentacam for this case. But anyways, it's a nice presentation. Thank you. You can ponder about that as well because the patient doesn't have, too much astigmatism to go with the pentacam analysis as well. So
yes.
thank you.
Thank you, ma'am.
Thank you, Kamalika. So energetic.
Thank you.
Okay. Next, Sahana, case number U54. Can you share me your slides?
Yes, sir.
Yeah, please go
I'm
ahead.
shared.
Yeah.
Can I start presenting?
Yes,
Sir?
please.
Good afternoon to everyone. I'm Sahana from SRM Medical College. First of all, I wish everyone a very happy World Optometry Day. Today, I'm going to present a case of complication of retinopathy of prematurity in preterm infants. So, ROP is a vasoproliferative disorder affecting premature infants. Sorry. Affecting premature infant, that is leading a cause of childhood blindness worldwide. And also the global prevalence of ROP among premature infants in last 4 decades was found to be 31.9%, and with the prevalence of severe ROP is 7.5%. Excuse me, I have problem in presenting it. Excuse me, can you hear me, sir?
Yes.
I have problem presenting slides. It's too slow.
Okay.
Is it visible now?
Yes, visible only.
May I just continue?
Yeah, please continue.
Thank you. So the patient is a twin male infant whose informant is his mother. So he had a birth history of 24 weeks and 6 days prematurity, and his birth weight was 710 grams and no history of consanguinity and ROP for his twin. And also the prenatal and perinatal factors were remarkable. So he underwent a routine ROP screening. So he was diagnosed with stage 1 zone 1 ROP without plus disease in both eyes. 1 month later, the condition progressed to APROP and he with zone 1 with plus disease. So he underwent IV Avastin as a treatment option. And again in 2023, the baby developed stage 2 ROP with NBE in both. So he underwent IV Avastin and laser photocoagulation. So in 2024, the mother reported that the baby have a complaint that he is not fixating the object, and also he squeezes his eyes frequently. So we did retinoscopy examination, which there was a dull glow in his right eye, and left eye was had a clear. And Sitlan examination revealed that PSCC in the right eye and left eye was within normal limit. And fundus examination, the fundus was within normal limit in the both eyes. And also the patient was advised to return to the clinic after 6 months. So after 6 months, the baby developed total cataract in the right eye. To confirm that, we did B scan, so which also confirms that the baby have total cataract in the right eye and left eye was within normal limit. And we did squint examination, so the baby had esotropia in right eye. And also we measured axial length under anesthesia. So we managed him by implanting IOL, and also we explained about the post-operative complications like secondary glaucoma, amblyopia, and need of corrective glasses lifelong. So we undercutted the IOL power and it was implanted in the right eye. So post-operatively it will be hypermetropic, and due to aging and elongation of axial length, it will shift to metropic in the adult, and there will be reduced the necessity of IOL exams. So in postoperative follow-up, the baby have a restriction in left eye occlusion. So we did visual acuity where it shows CUSUM, unsteady and unmaintained fixation in right eye, and left eye was normal. And we did cycloplegic refraction with homoterpine and tropicamide, which revealed anisomorphic refractive error, and with a add power plus 3 diopter in the right eye. And again, squint examination revealed right eye esotropia, and fundus was within normal limit. As a management, we prescribed executive bifocal for the right eye and single vision for the left eye. And we also introduced patching therapy to the baby for left eye for 1 to 2 hours daily to manage the stimulus deprivation amblyopia. And also, visual stimulation exercises were recommended to the baby, including light fixation and use of attractive toys. Discussion includes that this is the most common complication after laser treatment for orthopedy. Customized treatment should be provided according to the associated complications of orthopedy. So, cataract formation in preterm infants can be due to the ROP treatment or prematurity related factors, which this was highlighted in a study and previous study. And previous study also demonstrates that early visual stimulation and fluorescein therapy improves the visual acuity, and early visual stimulation treatments provides appropriate visual input in the future. And also, passing therapy is a key treating amblyopia from stimulus deprivation, such as cataracts, and its effectiveness varies based on the complication, and also it requires individualized plans and parental support. So, executive bifocals are recommended for pseudophakic infants, especially due to the requirement of addition cover, and also early prescription of full refractive correction is crucial for visual development. I conclude by telling that a multidisciplinary approach is essential to managing cataract in infants, with ROP focusing on early detection, timely surgery, and visual rehabilitation. And personalized visual stimulation and patching therapy support optimal development. Educating parents about potential complications ensure better understanding and adherence to treatment. These are my references. I sincerely thank you all for allowing me to present the case, and my deepest gratitude to the doctors and optometrists for their guidance. I especially thank Dr. Aishwarya, SRM Department of Optometry, SRM Medical College, for guiding me through this process, and also I thank OATN for the wonderful opportunity for me to present this. Thank you so much.
Thank you, Ma. It was very good having a multidisciplinary approach for an infant and then improving a vision as well. Just wanted to understand whether from the parents' side, like, did you teach them like any home therapies or anything like that, or else the visual stimulation things and the fixation activities, all it was done in a rehabilitation center, like, and what way it was advised?
It was advised as a home therapy, ma'am. We recommended them to use the fixation light toys having lights, and we advised them to use high contrast colored toys and use only one toy to grab the attention from the baby, ma'am.
Okay. Fine. Thanks. Thanks.
It's a nice presentation, Sahan.
Thank you.
That makes no sense.
Someone is talking?
Yeah, someone's talking, I believe.
Okay. Sahana, to you. I have two questions. The first question is, what do you think is the most important risk factor? Is it the gestational week or the birth weight?
It was gestational week, ma'am. And also, he's a multiple. He's a twin also, so that might be the reason.
Superman is the symbol of like superpowers when you are poor versus no superpowers but you're really rich.
Someone is who joined us. Saranya is talking. Are you talking with us?
Saranya. I'm so sorry.
That's fine. Yes, Ahana, you were telling something.
Gestational week is the strongest answer, ma'am. And he's also a twin, so that might be reason for the ROP.
I hope you go back and read on that, and if it's possible, just get me come back with the right answers. And the other question is, do you think we need to do a screening for ROP? Do you think that will work?
Yes, ma'am. Of course, regular follow-ups and the regular checkup of screening is very important.
Not the follow-up. I'm asking about the screening. For example, like how we go do the screening at schools for refractive errors and other conditions. Do you think is it possible to do ROP screening?
Yes, ma'am. NICU is important, ma'am. Neonatal.
Yes. Thank you.
Thank you so much, Sana.
Thank you, sir.
Yes. Next, Madhavan. Case number U55. Followed by Madhavan PV Gayatri. Be ready.
Good afternoon, sir. Myself Madhavan, and I'm currently doing an 4th year posing Bachelor of Optometry in Department of Optometry, SRM Medical College. Yeah, I will be presenting severe visual field constriction following recurrent posterior circulation stroke.
Yes, please go ahead.
Yeah, yes, sir. I have some problem.
Yes, Madhavan.
Thank you for the patience, sir. I will be presenting.
Yes.
Introduction: visual impairments, particularly homonymous hemianopia, significantly impact the daily life. The posterior circulation stroke affecting the occipital lobe commonly result in visual field defects, color vision disturbances, and transient vision, blurring of vision. Patients with recurrent strokes may experience additional visual field loss, which can severely affect mobility and functional vision. This case report presents with a patient with right homonymous hemianopia due to a previous stroke, who later developed further visual field constriction, sparing only the central 10 degree after a second circulation stroke. This is a case history. A 45-year-old male presented with severe peripheral visual field loss, difficulty perceiving colors, temporary worsening of vision upon waking, and challenges in mobility and recognizing the currency. These symptoms had gradually worsened over 2 months following a recurrent stroke 4 months ago. The patient had an acute ischemic stroke in 2021, which caused the right homonymous hemianopia with macular scarring. After a second posterior circulation stroke, his visual field loss worsened, leaving only central degree vision. There is no systemic illness, but a patient history of cardiac surgery 4 years ago. This is the findings of clinical findings. The patient's unaided visual acuity was both eye was 6/6, and the nearest visual acuity unaided in right eye was N12 and left eye was N10. There is an autorefractometer power with objective refraction. Subjective refraction, patient acceptance is plano in both eyes and the vision is 6/6. Add plus 1.5 were prescribed plus 1.5 as acceptance to read N6. Pupillary examination in right eye and left eye, there is a reactive light and there is no RFPD. IOP were measured with non-contact tonometer. Right eye was 11 mm HG and left eye was 14 mm HG. There is and the clinical findings: extraocular movements in both eye, full, free, painless, no diplopia. There is no restriction in all cases. Color vision with Ishihara displays in right eye 1/24, and out of 24 there is no written. Patient can't able to read 23 plates. In left eye there is zero number of plates. Patient read. Confrontation, there is a constricted field of view. We can able to see the images non-seeing area and seeing area. This is the HFA report from the patient, which shows significant peripheral field loss. This is the right eye and this is the left eye. The slit lamp findings and the fundus examination was normal. This is the management of this case: head orientation training and frontal ellipse prism. Head orientation is in proper positioning while during waking up to optimize cerebral perfusion and prevent posterior hypertension. Frontal ellipse prism, 40 prism base out in both ears to expand visual field up to 30 degrees. Initial discomfort improved after 2 weeks. Reading glasses for near work, mobility training, including strategies for scanning with head and eye movements to compensate for visual field loss. Psychosocial support, including counseling and guidance and disability certification and available concessions. The management of regular ophthalmic and neurology follow-ups to monitor vision and stroke risk. Stroke management, lifestyle changes, medications, and blood pressure and cardiac monitoring. This is a discussion. This case highlights the worsening of homonymous hemianopia due to a secondary posterior circulation stroke, which further constricted the visual field, leaving only the 10 degree of vision. Unlike Unlike progressive neurodegenerative conditions, the visual impairment resulted from an acute stepwise deterioration caused by recurrent ischemic shock. The first shock led to initial field loss, while the second exacerbated the defects. To address this, several rehabilitative strategies were employed. Prism therapy using frontal prism, 40 prism base out to expand the visual field, head orientation, and eye, and prescribed reading glasses to assist in currency identification. Additionally, psychosocial counseling provided emotional support to both the patient and their family, helping them adapt to vision loss. Managing stroke-induced vision impairment requires a multidisciplinary approach involving rehabilitation and psychosocial support, with early intervention and continuous monitoring playing a crucial role in improving functional vision and overall well-being. There is a two-article comparison between these. Psychofield and left in the article 1, which was I put in references, discusses various rehabilitation strategies like prisms and compensatory eye movements, whereas these case specifically addresses visual field worsening due to recurrent stroke and its impact on rehabilitation. And the another article, which is number on 4, emphasizes visual field impairment as a predictor of recurrent strokes. While this case focuses on managing hemianopia after recurrent strokes rather than predicting them. This is a conclusion of this case. Recurrent stroke can lead to worsening in visual impairments, requiring timely rehabilitation strategies such as prism therapy and head orientation training to improve functional outcomes. This case underscores the importance of early intervention, multidisciplinary support, and psychosocial counseling in managing stroke-related visual field loss and enhancing patients' quality of life. These are my references. And acknowledgement sincere thanks to VHS Hospital and staff, gratitude to the patients and their family for their cooperation and trust. Heartfelt gratitude to Dr. Aishwarya Radhakrishnan, Associate Professor, Department of Optometry, SRM Medical College, for our valuable support and mentorship. Thank you for the OATN for giving me an opportunity. Patient consent was updated. Thank you.
Good one, Madhavan.
Yeah, it was really
Yes.
good. Thank you so much, Madhavan. One question is like the patient having a stroke and is affecting the occipital lobe. Do you advise any other diagnostic tests to assess the visual potential and maybe the visual pathways or any dysfunctional changes that you were able to notice? And did you advise any such things to understand?
We have came with the report of CT and MRI now, and we performed the HFA report to confirm that field loss now.
No, I'm asking about the visual pathways because it is going to affect the brain as well.
VEP assess the function.
Yes.
The VEP
Yes. Yeah, correct. You're right. Okay, that's okay. But anyway, you got the answer. Thank you.
Yeah.
That was great.
It's a nice presentation, Madhavan. I just have one question. How do you prepare a patient before, or how do you counsel a patient when you prescribe frenal prisms?
We have prescribed frenal prism for expand the field. The patient had only 10-degree visual field. The frenal 40 prism, which gives 20-degree visual field. More than 40 prism is less the reduces size images and clarity and distortion, which makes distortion. As we advise the patient to use frenal prism for the visual field expanding, and also we have prescribed reading glasses for the currency identification.
Thank you. That's it.
Thank you.
Yeah. Next presentation is Gayatri, case number U57, followed by Gayatri, Aishwarya, Lakshmi Priya. Next one is.
Can you see my presentation, sir?
Yeah. Please go ahead. Yeah.
So myself, Gayatri. Hello. I can't. Can you see the slides, sir?
Yeah. Please go ahead.
Okay, thank you. Myself, Gayatri. Today I'm going to present about Fuchs heterochromic idiocyclitis. So here,
Fuchs heterochromic iridocyclitis is a rare chronic non-granulomatous form of anterior uveitis. It is most likely caused by infectious autoimmune diseases, hereditary factors, or sympathetic dysfunctions. So the symptoms are blurred vision, mild discomfort, photophobia, and floaters. It can be minimal or no pain. The signs of this Fuchs heterochromic iridocyclitis are in anterior segment there are stellate KPs, which are star-shaped deposits on the corneal endothelium and the mild anterior chamber cells. So in posterior, vitreous with snowballs and blurred optic disc margins are present, and complications of this case are like cataracts and glaucoma. So here you can so one second, I can't. So can you hear me?
Yeah.
So here in this picture you can see the stellate KPs, and here are the vitrectors. We can see the hazy media and blurred optic disc margins. Here,
Request all others to
so
mute,
proper
please.
Yes, please. Adirai, Miss Adirai, can you please mute yourself? Go ahead, Gayatri.
Thank you.
Yes, please.
One. So next. Ma'am, I can't change the slide. 1 second.
We can able to see the slides and can hear you.
I can't change the slide. 1 second. Okay. So the proper management of this results in a good prognosis if the patient was treated with the proper management. It is a rare condition globally. It was like 1 to 9 per million. So it typically occurs in adult. So here the patient came with a patient with the age of 34 with a male 34 male. He came with a complaint of gradual decrease in vision and with a mild pain since 1 month. There are no other specific ocular complaints, and the previous ocular history was no history of trauma and surgery, and not using any spectacles. So general health was he have a recurrent mouth ulcer since 1 month. So he have done a blood test here. So this reveals that elevated ESR and CRP, C-reactive proteins, which such systematic inflammation. So we also have a relieved fatigue and mild morning joint stiffness, and rest history was normal. So the visual acuity unaided, right eye was 6/9 and the left eye was 6/12. Here you can see here the iris were a hyperpigmented patch was seen in the iris, and stellated capes were seen in the endothelium of cornea, and AC cells were also present. Rest remains normal. IOP are within normal limits. So in fundus examination, we can say there is a dull foveal reflex and blurred optic disc margins, and also vitreous snowballs are present. So hence these were diagnosed as Fuchs heterochromic iridocyclitis. So the patient was managed with the topical eye drops like corticosteroids like prednisone and nepafenite, which is NSAID, and also Refres Quazal, which is a lubricant. And systematic management was also done for this patient. Follow-up was given 1 to 2 weeks or as we needed. So follow-up 1, which is after 2 weeks, there is a partial improvement with the reduced blurring, AC cells with a 1 plus, like fewer stellate KPs, reduced vitritis. Topical steroids and NSAIDs were continued, and also the patient were suggested to tap for steroid tapering was planned for the patient. So systematic inflammatory markers were also be suggested to reevaluate once again. So to check the ESR and CRP values. So follow-up 2 was after 1 month, significant improvement with their resolved systemic symptoms also being resolved. So all the slit lamp examination was normal, and also fundus examination is also normal. So visual acuity was 6/6, and there is a normal IOP. So topical steroids were tapered further, and also lubricants were continued for 2 more weeks. So here, in conclusion, so in our case, there is a bilateral fused heterochromic idiosaccharitis, and also and a systemic with associated with systemic inflammations. So it was being managed by topical steroids and NSAID, which has a great improvement. So in contrast, there is another case of FHI to rubella virus infection. So which was in this they have managed it by surgical interventions due to the delayed diagnosis of them, which had lead to complications like cataract and glaucoma. So mainly we spoke about the case responded to well to the early diagnosis and treatment, leading to a good prognosis. So whereas in the rubella associated FHI has been a delayed diagnosis, which have been resulted to complications like cataracts and glaucoma. So I would like to conclude that early diagnosis and individual treatment, and also close monitoring of the patient should be it is a crucial thing. So significant clinical improvement was observed in both ocular and systemic symptoms. So inflammatory markers should be re-evaluated, which also plays a major role. On ongoing follow-up will be more essential to prevent the recurrence of FHI or anterior uveitis, and to maintain the long-term stability. So these are my references. I would like to thank OATN team for giving me this opportunity, and also the patient for cooperation, and also Dr. Aishwarya Radhakrishnan, who have gave her guidance and support for us. Thank you.
Thank you, Gayatri.
Thank you, Gayatri. Just one question, okay? That's good.
Okay.
From the optometrist point of view, what are all the parameters that you would say you said like you need to have a close monitor follow-up for this patient? So what do you think those parameters which we have to focus on, and how did you educate the patient regarding this condition?
So mainly we early detection of those signs would be important for us to optometrists to find out the signs in slit lamp examination and fundus examination, and also including if we have to counsel the patient about the treatment. It is a important thing to uh, follow the eye drops, and continuation of treatment would be essential, because giving better treatment, or following the eye drops properly, one can reduce the symptoms. Like in our case, that has been done. The patient has followed the eye drops regularly, so I can counsel the patient that.
Okay,
So we can
thank
also
you.
explain about the complications if they are not followed.
Okay, thank you.
Thank you, Gayatri. It's a nice presentation. I think I'm going to ask kind of a follow question or the same question as Chitra ma'am asked.
Okay.
For example, if this is the patient and you know what the patient has, the treatment regimen, So when a patient comes, the same patient comes to you as a follow-up, what will be your focus on? So what test you will be focusing on? Think about the complication and
So
answer.
I'll be focusing on IOP, measuring the IOPs, and also slit lamp examination should be the main one.
Why do you want to monitor IOP?
Which is a complication of, if it is a delayed diagnosis or under diagnosis, it is a complication of FHI, right? Glaucoma.
Okay, thank you.
Thank you.
Thank you, Gayatri. Next presentation, ma'am. Aishwarya Lakshmi Priya. Can you share me your slides?
Yes, sir, sure, sir.
Yeah. Followed by Aishwarya Lakshmi Priya, Tony Blisson.
Sir, my slides are visible, sir?
It's not visible.
Sir, one second, sir. Sir, is
Yes,
it
please
visible, sir?
go ahead. Yes, now it's visible.
Good afternoon to all present here. I'm M. Aishwarya Lakshmipriya, studying BSc Optometry in Lotus Institute of Health Science and Management. Here I am going to present a topic on a twist in the tail and unusual vision treatment of CRAO. As we know, the central retinal artery occlusion is an ocular emergency. It can be caused due to the obstruction of retinal blood flow by the embolus formation that can lead to severe vision loss. And the common clinical features includes maurosis fugors, RAPD, optic atrophy in the later stages, pale retina, cattle tracking, and cherry red spot on the macula. The common causes includes vasculitis, emboli, giant cell arteritis, spasm, and the other common risk factors like diabetics, hypertension, and other cardiac diseases. The common treatment option for CRAO was usually the treatment is unsatisfactory because our retinal tissues cannot survive as ischemic for more than 90 to 100 minutes. So the proper management should be given within 24 hours. Here the case study, 52 years female came to the hospital for a second opinion of retina with a complaint of sudden diminution of vision noticed at OS while after wake up since 3 days back. Patient using glasses for 13 years and he has been taken medication for systemic rheumatoid arthritis since 10 years. And there is no allergic history and family history. On that day, her visual acuity in OD was 6/6 with N6 at 33 centimeter and OS vision was CF at 1 meter with no pinhole improvement. And near vision for OS was less than N36 at 33 centimeter. And her acceptance for OD was plus 0.5 diopter with a BCVA of 6/6 and for OS was plus 1 diopter with a BCVA of CF at 1 meter and plus 2.25 diopter sphere is given as an ad for both eyes, but there is no visual improvement for near vision is noted with this acceptance in OS. And the pupillary examination shows there is no abnormal reactions of pupil and the absence of RAPD. And IOP evaluation revealed 12 mm Hg of IOP for both eyes. And 13-2 and 10-2 visual field examination revealed advanced field loss in OS. And keratometry evaluation revealed K1, K2 values are normal for both eyes. And fundus examination and OCT examination shows some changes in retina, such as in fundus examination, pale retina and cherry red spot on the macula and with the absence of retinal atrophy. In OCT examination, revealed some changes in RPE layer. So the final diagnosis for this case was CRAO. On her first visit, her vision in OD was 6/6 and OS vision was CF at 1 meter. So the doctor, so the ophthalmologist advised the patient for cardiac checkup and blood examination. Regarding these reports, the blood examination results revealed increased A/G ratio and eosinophil count. In carotid Doppler ultrasound scan revealed narrowed and plaque formation in the proximal ICA. And so the physician advised the oral ecposterin for reduce the carotid artery changes. On her second follow-up, her vision on OS is improved from CF at 1 meter to CF at 4 meter. And the fundus examination shows normal findings for both first and second visits. On her third follow-up, after a week, so once again, sir, some error. So can I continue, sir?
Yes, please, go ahead.
On her third follow-up, after a week of second follow-up, her OS best corrected visual acuity was 6/24 paths. And on her fourth follow-up, after a 10 days of third follow-up, her OS best corrected visual acuity was 6/24, and the doctor advised the patient to repeat the carotid scan and blood examination, and also also the ophthalmologist advised the Viaslone for prevent the future inflammatory changes of carotid artery. Here we can in the first and second follow-up reports. Here we in fundus examination report. Here we can notice the common CRAO changes, and in OCT examination reports shows some RPE bumps. On her fifth follow-up, after a week of fourth follow-up, her BCVA in OS is 6/18, and near vision is improved by 6 at 33 centimeter. And the treatment and management for this case was oral ecosprin, a vasodilator, and antiplatelet aggregation agent for treating the carotid artery problem, and oral Viaslone is an anti-steroidal inflammatory drug to reduce the inflammatory changes in the carotid artery. And the discussion part was vision retirement in CRAO is not possible in all cases, especially after the 3 days of presentation. But in this case, it was achieved by treating the underlying causes of carotid problem with appropriate ecosprin and Viaslone treatment. If the patient would have visited the clinic earlier, the visual acuity would have been better than 6/18. The final conclusion part was a rare significant visual recovery in CRAO, and the positive outcome in this case due to the treating of underlying causes, that is narrowed and plaque formation in the carotid artery, was resolved. And these are the references we taken for this case. Thank you so much for this golden opportunity.
Thank you. Over to judges.
Yeah, thank you. Sorry, forgot what is the name. Sorry.
Aishwarya.
Aishwarya. Yeah, thank you, Aishwarya. One question is, even in case of the absence of the fundus sign, suppose if there is no changes as of in case of CRAO, which is the best diagnostic tool to understand about this disease condition? And what you will see in CRAO in that particular diagnostic test or a tool maybe. It is there in a slide itself.
Yeah, okay, ma'am.
It is there in a slide itself. The answer is in your slides. Go back to slides.
No, one second, ma'am.
No? What is this?
Ma'am, I can't hear, ma'am.
What is this test which you have done?
Fundus photography and OCT examination.
So OCT examination will reveal you even there are no fundus significant changes are not seen. So this is the best tool to understand about CRAO. And in cases of CRAO, what are all the OCT changes that you look into? Just one more question. This is the last one. What are all the changes that you're looking for? Aishwarya?
Ma'am, I can't hear, ma'am.
You can't hear? And so the other people can hear? Ambika? You can
Yes,
hear?
ma'am, I can hear you.
Yes, yes. Okay, fine. Maybe I can pass on, go to Ambika.
No,
Thanks,
I don't have
Aishwarya.
any questions. Thank you, Aishwarya. Thank you, ma'am.
Okay. Next presentation is Tony, followed by Tony Sailesh. Be ready, Sailesh, for next presentation.
I'm audible, sir.
Yes. Yes, Tony. Please go ahead.
Good afternoon, everyone. I'm excited to present my topic. My name is J. Tony Blesson from Karunya University, Coimbatore. I'm doing internship at Dr. Raghavar Aya Hospital, Madurai. My topic was from blurred vision to clarity, managing VKH syndrome and optometry perspective. My introduction, wired Koyanagi Harada syndrome, VKH, the rare multi-system autoimmune disorder that affecting the eyes and skins and the hairs. Etiologically believed to involving the autoimmune response against the melanocytes. Symptoms was ocularly uveitis, lost vision. Neurologically, headache and midnight-like symptoms. Dermatologically, the symptoms are vitiligo and poliosis, like the gray hairs in the eyebrows. And auditory, the symptoms were hearing loss. Epidermologically, the topically patients are age 20 to 50 years. The people 50, the female 77% will be affected, especially Asian and American will be affected. The diagnosis was based on the clinical perspective and imaging and laboratory tests. This case studies undergoes the crucial role of optometrists in identification in the disease through the ocular signs and highlighting how early detection during the eye examination can lead to timely innovation and improving the patient outcomes by addressing underlying the health issues before the escalate. My case study was about the patient is 49 years old female with a history of bilateral DCA performed for the chronic nasolacrimal duct obstruction. He had a no significant systemic illness, reporting phenomenon to the onset of fear symptoms. His chief complaint was blurring vision in both eye and pain on both eye and hearing difficulty. And he denied the history of trauma and denied the history of infection condition. And clinical study, we have go through the visual acuity in right eye 6 by 24 and left eye 5 by 60. Then clinical finding in slit lamp was chaotic perceptive was present in both eye and Sugicara signs are present in observed in both eye and congenital discharge were of infection or neglect in this disease. Fundus examination was the sunset glow appearance. You can see the sunset glow in appearance in the both disc, both fundus photography, and indicating the depigmentation of the choroid and optic disc. You can see the disc edema in both fundus photography, and you can see the diffuse choroidal swelling and multiple serous RE and choroidal folds. You can see the B scan and OCT findings. In both B scan and OCT, you can see the choroidal thickening, and you can see in OCT, you can see intercranial cystic space, and she had a executive RD also. She had a serious RD judgment also. In B scan, the last image, you can see the separating separation. In advanced stage, it indicates the T sign, the hypoechopic space around the optic nerve head caused by the accumulation of the giving appearance of the T sign. Then treatment and management. The patient was diagnosed with BKH syndrome based on her clinical perspective and examination finding. The aggressive treatment plan was implemented to control the inflammation, present the visions, and prevent the systemic complication. We treated that by systemic corticosteroid and adjunctive supplemental treatment and management hearing difficulty. In systemic corticosteroid, we give the high dose oral corticosteroids were started for managing the inflammation, and the doses was gradually trapped over the severe week to minimize the side effect of the prevent recurrent. And cycloplegic eye drops were prescribed to alter the ciliary muscles from an ocular pain. Lubricant eye drops also provided reduce the dryness and irritation and refers to the ENT specialist for made the evaluate management hearing issues associated with systemic nature of BKH. The discussion. The follow-up visit, the patient demonstrate remarkable recovery following promotes initial of the systemic corticosteroid therapy, visual acuity improved. You can see the visual acuity was improved from the 6 by 24 to 6 by 12 unaidedly in right eye, and you can see 5 by 62, 6 by 36 unaidedly in left eye. The system of ocular pain and hearing difficulty also result with the treatment and inflammation subside as observed during the
following slit lamp and fundus examination. The outcome highlighting the benefit of the early diagnosis and innovation by remotely addressing the information of systemic manifestation, the patient quality of life was preserved and future complications were avoided. You can see the OCT finding after the treatment. The OCT finding reflects a significant improvement in the patient condition. In OD, you can see reduced from 354 foveal thickness to 275, and in right eye you can see 556 view to 360, and resolving the choroidal folds and suggests to treatment to effectively control the inflammation and the fluid accumulation. The resolving subfluid also you can see. The conclusion: the case study emphasized that the critical role of optometrists in early detection and management of systemic disease with ocular manifestation, such as BKH syndrome, has the patient's symptoms of bilateral visual blurriness and ocular pain and hearing difficulty was the key detection. The key takeaway was early detection, interdisciplinary collaboration, and timely innovation. The early detection was recognized the hallmark sign of Sugihara sign and the sunset glow fundus appearance in the crucial for timely diagnosis and innovation, and effectively management recovered teamwork among the optometrists and ophthalmologists and other specialists as to the nature of PKH. Starting corticosteroid therapy and systemic management early signify the improvement of outcomes and prevents the future complication. Let's continue work together to improve the early detection and care of VKH and other ocular disease. I wish the World Optometry Day. I wish for the world where vision care is accessible to all and optometrists continue the vital role in detection and preventing the systemic disease, improving the lives one eye exam at time. Maybe work together to create a healthier and further future. Thank you. Thank you for the great opportunity, OATN.
Wonderful, Tony.
Thank you so much, Tony. It was like a clear-cut explanation of how an optometrist should proceed. I don't have any questions now. Maybe Ambika can take up.
I can, yes, you very well summarized what the role of optometrist in early detection, but can you tell me what could be the other roles that an optometrist can play in such cases? Let's take the VKH itself. Where do you think?
I mean,
yes.
Tell me.
No, like I understand completely. Now I get all the knowledge that early detection is key and optometrists play an important role there. So where an optometrist can help this patient after that, after the detection?
By optometrists can help by in technical support, like OCT findings and other B scans. We can help the ophthalmologist to identify the disease, and by patient support we can help by following the patients. By following the vision improvement, we can note the special diseases and following the improvement of the vision.
Okay. Thank you.
Thank you, Tony, for the wonderful presentation.
Yeah, thank you, sir. Thank you.
Yeah. Next, Mrs. Sailesh. Case number U63. Please go ahead.
Good afternoon to honorable presenter. I'm Sailesh, fourth year intern from the SRM Medical College. Pagolytic glaucoma is a type of secondary open-angle glaucoma in which trabecular muscle is blocked by the lens proteins and macrophages, which are phagocytes the lens proteins. Trabecular blockage occurs when high molecular weight lens proteins seep into the aqueous humor from the intact optic. So symptoms include pain, decrease in vision and redness, and signs corneal edema, deep anti-assembly depth, and pseudohypopia will be present. And this is the picture of hypermeasured cataract. Case history: a 63-year-old male referred from Sri Ramakrishna Max Charitable Dispensary and Diagnostic Center to VHS Hospital. Left eye had a history of hypermeasured cataract since 2 years. Right eye history of cataract surgery done since 2 years back. He had no history of DM or hypertension. Family history was not significant. Clinical file is unaided visual acuity was 6/6 in the right eye. and in the left eye it was perception of light plus. IOP was done with eye care. It shows 19 mm Hg in the right eye and 73 mm Hg in the left eye. And EOM was performed. There was a mild adduction restriction in both the eyes. And Erzberg, it shows left eye exotropia. Pupil examination was done. Both eyes round and reacts to light. No RAPD. Slit examination, right eye was within normal limits and lens was replaced with the PCIOL. In the left eye, conjunctival congestion was present and yes, the presence of AC cornea and anterior cerebral depth was deep with the Van Eyck grading. So this is the picture of the patient which shows pseudo-hypopyon and hypermeasured cataract in the left eye. And this is the slit picture, shows the AC corneal view and AC depth, deep AC depth. So this is the B scan image, which shows the retina was intact, and A scan was done to measure the axial length calculation for surgery. So management and treatment. For management, tablet Diamox was prescribed with hydros, predford, and moxigram and cyclopentolate. Diamox was prescribed to reduce the IOP. Predford is a steroids, and moxigram was prescribed to reduce the congestion, and cyclopentolate for relief pain and for further management. Treatment, cataract surgery was done with IOL implantation. So discussion, phagocytic glaucoma is typically handled as an emergency. In a prospective observation study conducted by Kolkata National Medical College in 2012-2013, it was found that the majority of the patients achieved a post-operative best corrector visual acuity of more than 20 by 125 after completion of follow-up, highlighting the effectiveness of timely surgical intervention in improving visual outcomes for the patients with phagocytic glaucoma. So conclusion, phagocytic glaucoma is a complication of hypermeasured cataract and typically occurs in elderly patients. Cataract surgery remains the definitive treatment, reducing intraocular pressure and preventing permanent vision loss. Early detection and timely intervention are crucial in preventing severe complications, emphasizing the importance of routine eye examinations, particularly in elderly individuals at the risk of advanced cataracts. So these are my references. And sincere thanks to VHS Hospital and staffs, gratitude to the patient and the family for the cooperation and trust. And special thanks to Dr. Aishwarya Radhakrishnan, Associate Professor from the Department of Optometry, the SRM Medical College. And sincere thanks to OATN for giving me this opportunity. Thank you.
Thank you, Sailesh. Thank you for the presentation. One question is like you have mentioned that the patient had been given, was advised for cataract surgery, right? So as an optometrist, after that, what is the parameter that you would focus on for the patient care?
We have to, for the follow-up, we have to focus on the IOP now. Then
IOP
improving in vision.
Okay. So how do you differentiate between this phacolytic glaucoma and phacomorphic glaucoma? How would both, because both are lens.
Phacolytic glaucoma, the lens proteins will be breakdown and it get attached to the occlusive nerve. So the blockage occurs.
What is phacomorphic?
In phacomorphic, the lens will get bulged up.
Due to what? Okay, maybe Ambika, you can take up.
I have one question to you, Sailesh. It was a nice presentation. You also mentioned in your case report about phacogenic uveitis. Can you just tell me the difference between phacolytic glaucoma and phacogenic uveitis? How do you differentiate, or whether you need to look for something else when you also, handle a patient
Phacogenic
having
phacogenic uveitis is an autoimmune condition.
autoimmune condition.
Immune system, where the immune systems attacks the lens protein, causing lens injury.
So, what are the signs you would look for when you're examining a patient?
Okay.
What are the signs you would look for in case of phacogenic uveitis?
The photophobia will be there, no?
Okay.
And mutton fat precipitates will be there in phacogenic uveitis.
Thank you.
Thank you, Salesh. Next presentation is Shivani.
Yeah.
Followed by Shivani. Mohammed, be ready. Please go ahead, Shivani.
Okay. Is my screen visible?
Yes, visible. Please go ahead.
Good evening, everyone. Myself Shivani C, pursuing my third year B.Optom in Dr. Agarwal's Institute of Optometry, Chennai. My topic is on management of bilateral uveal effusion syndrome with primary angle closure and ocular hypertension. Uveal effusion syndrome is a rare ocular condition characterized by serious choroidal detachment, intraocular inflammation, and angle closure changes. It is commonly associated with hyperopic scleral abnormalities or idiopathic causes. In certain cases, uveal effusion syndrome may coexist with primary angle closure and ocular hypertension, adding complexity to its management. The prevalence of uveal effusion syndrome is notably low. However, uveal effusion has been observed in 9% of eye with chronic primary angle closure in an Asian population. A 45 years male came with a complaint of watering since 20 days in right eye and redness pain associated with headache and strain since 20 days in both eyes. He is a known case of acute angle closure glaucoma. History of diabetes since 6 years and history of seizures. Family history was not contributory. Under medication for diabetic mellitus and acute angle closure glaucoma. Allergics were not aware of. Clinical findings. His uncorrected visual acuity is shown here. His refractive values were 0.5 diopters in both eyes at plus 0.5 diopters. Ocular motility was normal findings. IOP was measured using applanation tonometry. Right eye 21 mm Hg, left eye 22 mm Hg, which is ultimately reduced to 9 mm Hg and 12 mm Hg at 10:30 am. Gonioscopy. Right eye complete closure. Left eye superior quadrant alone shows grade 2. All other are grade 1. On slit lamp examination, circumciliary congestion noted in both eyes, sluggish pupil reaction in both eyes, anterior chamber cells. Lens shows early changes. Fundus examination was normal with media is. B-scan and fundus picture findings of uveal effusion syndrome. OCT picture shows uveal effusion syndrome, superior, inferior, nasal, retinal detachment without retinal breaks, fine macular folds were also present. Right eye was more severe than left eye. Diagnosis and management. Bilateral uveal effusion syndrome with primary angle closure, ocular hypertension, and post-traumatic glaucoma. Management. Systemic treatment. Valzalone 40 mg tapering over 4 weeks. Topical treatment. Predforod 6 times daily, tapered to 4 times. Follow-up after 1 month. Findings. Persistent conjunctival congestion, tortuous vessel, shallow anterior chamber, anisocoria in right eye, dull foveal reflex with ILM folds. Management as same. Follow-up to findings. Continued vessel dilation, shallow anterior chamber with +1 cells, ill-sustained pupil in right eye, hyperemia disc and ILM folds. Follow-up 3. Findings. Dilated torsional vessels, shallow ACD with +2 cells and flares, anisocoria with ill-sustained response, PAC positive on gonioscope, cup disc ratio 0.2, ILM folds, and an inferior atropic patch. Previous diagnosis, bilateral uveal effusion syndrome with suspected Wicked syndrome. Management, topical, dexamethasone, brinzone, and brimonidine plus timolol. Systemic, steroids initially withheld due to uncontrolled diabetes with plans for gradual tapering once glycemic control improves. Next follow-up, review in 1 month with an focus of glaucoma elevation and monitoring for disease progression. Discussion. The management of uveal effusion syndrome with primary angle closure and ocular hypertension prioritize IOP control, inflammation reduction, and systemic considerations. Previous study has reported with systemic steroid IOP lowering agents and yearly LPI, whereas our case achieves stability with caution steroid tapering due to diabetes and medical management alone. Ciliochoroidal effusion must be distinguished from solid tumors like ring melanoma to avoid unnecessary enucleation. It may occur idiopathically or in specific disorders like weak syndrome or UES. Conclusion. This case underscores the need of multidisciplinary coordination in managing UEC in patients with systemic contributions. Regular follow-ups, gradual steroid tapering, and effective IOP control were crucial in achieving long-term stability. Close monitoring and a tailored approach balancing inflammation control and systemic risk remain crucial. Individualizing treatment approaches remains essential, particularly when balancing systemic risk and ophthalmic management. These are my references. Thank you. I would like to thank OATN team for giving me this opportunity.
Thank you, Ma. Can you just go back to your slides? Why there is a change in the intraocular pressure within a 1 hour time period? It was 22, I believe, and then later on I went to, this is another person slider. Not choroidal osteoma. Yeah. Yeah, this one. What is the reason behind it?
Because glaucoma medications were given.
Oh, within a 1 hour time period.
Yeah.
Oh, fine. Thanks.
I just wanted to look at your topic, and I want to know whether is there any difference between primary open angle glaucoma and ocular hypertension. So actually, what's the difference? Can these two coexist? Can you start with the actual difference between PAC and ocular hypertension, please? Hello? I think I'm audible.
Yes, ma'am.
Anyways, you
Shivani?
can go look at that. And also, is there any other test that you wanted to do for this kind of patient? Do you want to look at any structures thickness?
Ma'am, can you please repeat?
Which question you want to? I asked you two questions. I need to know whether.
Yeah, first question is pressure with field changes in glaucoma, ma'am.
Which is what?
Primary angle.
Okay, so what is ocular hypertension means?
Ocular hypertension in which IOP alone will be raised.
Mm-hmm. With or without the changes with the optic nerve?
Without changes.
So how can this both can coexist in a case? Just go ahead and look back at the case clearly, and also you can also look for other tests, important tests that you have to do before concluding. Also it will be helpful for you to differentiate between these two. Okay, thank you.
Okay, thank you.
Thank you, Shivani. Next presentationer, Mohammed. Yes, followed by this, Nitisha. Next one, be ready. Yes, Mohammed, please go ahead.
Good afternoon, everyone. Myself, Mohammed Shakik, studying third year B Optom in Dr. Agarwal Institute of Optometry in Chennai. The presentation topic of today is choroidal osteoma with secondary choroidal neovascular membrane, a rare cause of progressive vision loss. Introduction. Choroidal osteoma is a rare benign ossifying tumor that may impair vision due to retinal pigment epithelium atrophy, choroidal neovascularization, or subretinal fluid accumulation. This case report present an unusual manifestation of choroidal osteoma and its clinical significance. While choroidal nevi are generally benign, the risk of malignant transformation into choroidal melanoma, necessitating long-term monitoring. So, case history. A 46-year-old male patient presented with a chief complaint of blurring and diminution of vision since 6 months in right eye, with no other specific ocular complaints in both eyes. The previous ocular history of patients with the history of glasses since 5 years with his PG lost. He also had history of diabetes since 20 years and under medication. The family history was not contributory. Current medication for under medication of diabetic mellitus. Allergies, not aware of any. The clinical finding of the patient, the uncorrected visual acuity in right eye 6/12 with pinhole 6/9 and the near visual acuity is N26. For the left eye 6/9 spots with pinhole, the patients read 6/6 and the near vision is N6. So the refraction is not done. Ocular motility shows normal. The IOP using applanation tonometry in right eye shows 13 mm Hg and left eye shows 14 mm Hg. The slit lamp examination tend to be normal. The fundus examination revealed scarred choroidal neovascular membrane in right eye, drusen in both eye with progressive pigmentary changes in both eye. So there are fundus pictures. Diagnosis and management. Diagnosis: unspecified chorioretinal scars in right eye, requiring close monitoring and potential therapeutic intervention. Follow-up 1 shows the symptoms of persistent blurring in right eye, the visual acuity, the uncorrected visual acuity in right eye 6/60 with pinhole 6/24, in left eye 6/9 with pinhole 6/6. The anterior segment normal in both eye. The fundus reveal the progression of pigmentary changes, drusen and yellowish macular lesion indicating choroidal osteoma with a secondary choroidal neovascular membrane. In fundus revolution in left eye, stable with mild drusen and pigmentary changes. Follow-up 2 shows the symptoms of persistent blurring and diminution vision in right eye. So the visual acuity, no changes from previous visit. Anterior segment also no changes from previous visit. The fundus examination revealed in right eye progression of yellowish elevated macular lesion consistent with choroidal osteoma and persistent secondary neovascular membrane. OCT finding choroidal mass with pigmentary epithelium detachment and subretinal fluid drusen retinal cystic spaces. B-scan hyperrefractive lesion in right eye. The management, the advised moisten eye drop, utivate capsules and referred for OCTA evaluation. So these are OCT findings. OCT picture depicting choroidal mass with pigmentary epithelial detachment, drusen, subretinal fluid and retinal cystic space. Discussion. Choroidal osteoma with secondary choroidal neovascular membrane is a rare condition characterized by the yellowish elevated macular lesion as observed in this patient. Similar cases in literature report progressive visual deterioration due to CNVM, associated subretinal fluid and retinal cystic changes. Studies highlight OCT and B-scan as key diagnostic tools, revealing choroidal masses, pigmentary epithelial detachment, and hyperrefractive lesion. While prior case report variable response to treatment, close monitoring remain crucial to prevent irreversible vision loss. The conclusion, this case highlight the progressive vision loss in choroidal osteoma complicated by secondary neovascular membrane. Choroidal neovascular membrane, stressing the importance of early detection and timely intervention. Regular follow-up is crucial for monitoring disease progression and optimize visual prognosis. So these are my reference, and thank you for my mentor, Miss Meenakshi ma'am, and thank you for OATN teams. Thank you very much.
Thank you, Shakir. Only one question. So, what are the differential diagnoses for choroidal osteoma? And was the vision maintained or it was stable even after the treatment? Did you have any reports regarding it?
And the differential diagnosis mean the posterior staphyloma.
Posterior staphyloma.
Mean what, ma'am? What question?
What are the differential diagnoses for osteoma, choroidal osteoma? Okay. Was the vision maintained and was stable even after the treatment?
Yes, I mean melanoma, ma'am. The differential diagnosis of the osteoma, I think, is melanoma.
It's hemangioma. Okay. Yeah, regarding the vision, do you have any report like was it stable even after treatment?
Yes, ma'am. In his first and second follow-ups, there are vision no changes anything, ma'am. They are stable.
Okay. Okay. Thank you.
Okay, thank you, ma'am.
Thank you. I have one small question to you.
Yes,
You
ma'am.
said that for such cases, OCT and B scan is very important. But
Yes.
optometrists usually, even if they are, having an independent practice um, or have a small clinic, they won't be having OCT or B scan with them, and B scan we can't do that. So, how do you propose an optometrist's role in such cases, where we can play a role here?
Yes, fundus examination can help, ma'am.
Oh, okay. How do you think it will help us?
Ma'am, we can use DO, IDO, or 90D for sit. What, ma'am?
Yes. No, nothing. Yes, yes. I was expecting some signs
Yes,
that you
ma'am.
would say that is there already in in your in your slides. Anyways, that is fine. Thank you.
Okay, ma'am. Thank you, ma'am. Thank you so much.
Yeah.
Yes, Nitisha, you can start. Yeah. Your voice is very low.
Clear now?
Still, your voice is low.
Is my screen visible now, sir?
Yeah, screen is visible. Now you are audible. Fine. Please go ahead.
Okay. Sir. Good afternoon to one and all present here. Myself, Nitisha, pursuing my third year B Optometry at Agarwal Institute of Optometry, Chennai. I'm here presenting an unusual case of ocular surface squamous neoplasia. The background of my study. Ocular surface squamous neoplasia is a... Sorry, sir, excuse me. Ocular surface squamous neoplasia is a type of ocular tumor with an incidence ranging from 0.0 to
0.03 to 1.9 per 1 lakh persons per year. The diagnosis is made on clinical suspicion and confirmed with anterior segment optical coherence tomography, cytology, or histology. Surgical excision remains the primary treatment, which is often combined with adjunctive therapies to reduce the risk of recurrence. However, post-excision complications are not uncommon. Vascularized scarring can develop due to conjunctival remodeling and healing responses, while conjunctival cyst formation may result from retained epithelial cells or disrupted conjunctival tissue during surgery. Case history. A 70 years old male patient presented with a complaint of swelling and redness in the right eye since 10 days and no other specific ocular complaints. And his ocular history is not contributory. He had an history of craniotomy since 10 years ago with history of hypertension and elevated cholesterol levels since 3 years, for which he is under medication. History of seizures 2 years back, for which he is also under medication. His family history is not contributory and he didn't underwent any recent investigations. He is not aware of any of the allergies. His ocular examinations revealed uncorrected visual acuity for distance in the right eye is 618 and 612 in the left eye. His near visual acuity is not done and his refraction is deferred. His extraocular motility showed full, free, normal, and painless movement in both the eyes. Slit lamp findings revealed normal upper and lower lid with clear anterior chamber, pupils reacting to light, while in the right eye, conjunctiva, elongated oval swelling measuring 5 into 10 mm is observed, and in the left eye, mild pannus formation in the limbal region is seen. This is the image which depicts conjunctival oval swelling in the right eye and pannus formation in the left eye. This OCT depicts the conjunctival oval swelling in the right eye. His fundus examinations revealed normal findings. Diagnosis and management. In the right eye, oval swelling of 5 into 10 mm and congestion around the conjunctiva with a feeder vessel indicated a tentative diagnosis of ocular surface squamous neoplasia. Ocular surface squamous neoplasia in the right eye, excision biopsy with amniotic membrane graft and cryotherapy is advised for the patient. Post-excision and biopsy, follow-up 1. In the right eye, post-excision biopsy of ocular surface squamous neoplasia (OSSN), along with amniotic membrane graft and cryotherapy, his ocular findings revealed 636 in the right eye, which is uncorrected visual acuity, and other observations in the right eye revealed mild upper lid edema with conjunctiva displaying amniotic membrane graft in situ. Wound from the excision appeared healthy with intact sutures. Cornea exhibited no significant abnormalities. During the follow-up 2, which is 1 month later, his ocular findings revealed uncorrected visual acuity in the right eye, improved up to 6.9, and his intraocular pressure was elevated. His slit lamp findings revealed congestion in the conjunctiva with mild anterior chamber flare and uveitis, whereas amniotic membrane graft was in situ. The uveitis and congestion were managed with mild steroids and antibiotics. Follow-up 3. The patient came up for the subsequent visits. The patient reported no chief complaints, whereas his uncorrected visual acuity in the right eye remained 6.9 and his IOP in the right eye was mild elevated. His slit lamp examination revealed small inferior conjunctival cyst with nasal vascularization post biopsy, along with inferior pannus with mild meibomian gland dysfunction. Lubricants and steroids were continued with a tapering regimen. The picture depicts the conjunctival cyst and OCT picture also depicts the same. Discussion. In comparison with the reported cases with ocular surface squamous neoplasia presenting with an elongated oval swelling and feeder vessel, our case demonstrated nasal vascularization and a conjunctival cyst post-excision. Ocular surface squamous neoplasia is known for its low-grade malignancy and a favorable prognosis, with a low risk of lymph node or distant metastasis. However, the most critical prognostic factor for recurrence remains the presence of neoplastic cells at the surgical margins. This comparison underscores the importance of vigilant postoperative monitoring to ensure timely detecting and management of the potential recurrences. Conclusion. Initial evaluation showed right eye ocular surface squamous neoplasia with cataract and minor changes in the left eye. Post-surgery, the right eye had improved vision, mild lid edema, and a stable graft. Elevated intraocular pressure, mild uveitis, and a conjunctival cyst were managed with steroids and antibiotics. Many cases are often treated successfully with excision biopsy combined with adjuvant topical chemotherapy and generally carry a favorable prognosis. Recurrence of ocular surface squamous neoplasia is possible with an overall rate of 12.9%. Hence, early management is advised in such cases.
Hello.
Thank you.
Yeah, thank you. Can I just let me know what are the other ocular signs that you're looking for when there is an OSSN?
Sorry, ma'am, can you repeat the question?
What are the other ocular signs that you were looking for when you see an OSSN patient?
Congestion will be seen, ma'am, which is already present in this case itself.
Okay.
Other ocular signs will be uveitis and meibomian gland dysfunction.
Why meibomian gland dysfunction?
Due to inflammatory responses of neovascularization. Poor tear film will be secreted there. So,
Okay, thank you, Nitisha.
okay, ma'am, thank you.
Thank you, Nitisha. I have one question. How do you rate the risk factors for this patient? Like, what are those risk factors for OSSN? Very straightforward question.
Risk factors include UV radiations, ma'am. Like, is systemically if he has any HIV virus or HPV virus infections.
HIV?
HPV
Okay.
virus.
Yeah, it's also possible. Immunosuppressant
If he is
patient can
also
also.
immunosuppressant patient, yeah, AIDS patient, or if the patient that already undergone any organ transplant, they'll be more prevalent to this ocular surface inflammation.
Okay, so what are the post-surgical complications to expect in the patient, and most of which the patient has actually developed?
Yeah, conjunctival cyst is already developed here. Post surgical, we can also expect. I'm not very sure about the answer.
Hey,
Sorry.
you already mentioned, in your slides as well. Anyways, thank you. Thank you.
Yes, thank you. Am I audible?
Yes.
Okay. Yes, ma'am. Thank you so much for taking your time. Chitra ma'am and Ambika ma'am, thank you so much for being with us. And once again, our optometrists have proven they are very excellent in clinical side, and they're just concentrating on clinical level. They will shine in future level with clinical knowledge. And thank you for your support. And the results of this will be announced by tomorrow, but through the mail. We'll send you the results about the details for all the winners, and all the details will be shared by tomorrow. And once again, thank you so much. Thank you, ma'am.
Thank you, Simpson, and thanks, Preeta, for giving us the opportunity to be as judges for this excellent participants over here. I was wondering that those days back and now after 2 decades, how the optometry has improved a lot with all of different kinds of cases that is being presented in this platform. I actually thank you for that. And all the participants, you people really did very well. And that too at the third year level itself, so third year or the final year level itself. I wish you all the best and success in your future ahead. Thank you.
Thank you, ma'am.
Thank you. For me, this is the maybe I'm starting my career, and like Chitra ma'am who has really, as she said, 2 decades of her experience in optometry. It's very humbling and I'm very thankful to Preeta ma'am for asking to evaluate such an interesting, and their excitements were very contagious. Like, there are so many opportunities available, and thank you OATN for providing this platform for those uh, budding researchers, even when they are in the student category. So many abstracts I had yesterday till 12 o'clock. I was reading all the abstracts, and the case reports, and I was noting down all of that, and it's an extreme reading assignment to me. And thanks Preeta ma'am, it was very wonderful opportunity you have created for me. All the best to all the students here, and you really did well. In fact, I read most of your cases, like little bit of putty tinkering and everything, is very very nicely written. And a few I have a few, maybe I can say maybe an tips to you. There is a care guidelines. Whenever you're, go ahead and publish your research in any journal, based on your research design, you have to go through some criteria. So whenever you're writing any type of such research, you can go ahead to Equator guidelines, and where you can find for, if you're writing a case report, or if it's a cross-section study, or if it's any studies, study design, you will have a checklist given there. So make sure that you tick all of that in that, so it will be more robust when you are presenting to any forum like today. That's my tips to you guys, and thank you for the opportunity. Thank you Simpson for moderating this session. Thank you Chitra ma'am.
Thank you, ma'am. OATN always will guide in a good way and motivate our optometrists to shine like a bright light.
Thank you, Ambika. Sorry.
Diamond. There's a song.
True.
Okay.
Right. Thank you so
Thank you, ma'am. Thank you so much.
Yeah.
Okay.
all.
See you all
Bye.
in next
Bye,
another
ma'am.
session soon.
Of course, to evoke, I take this opportunity
Yeah.
to welcome you all to evoke. Don't forget that.
Okay.
I wholeheartedly welcome you all. Be present there, and get that research intense
Okay.
sessions from my work 2025, August 15 to
Okay.
17.
Okay. See you all in Ewok.
Yes.
That's great.
In person.
Okay.
And for
Person.
me, when I was a student, I was in fourth year when 2015 evoke happened. It was like a big event. I don't know where I have to go, which session I have to attend. So it was very confusing for me when I was a student, and it was a great experience to be there. Even I did not present anything, but I was there, getting all the experience. So it will help you get ready for the next 5 years in your optometric career. Please be there.
Yeah. Yeah, definitely.
It's a good platform to invite all these buddies.
Oh, yes, it's a big platform. It is thank you,
Yeah.
Simpson sir, giving me extra minute to talk about your work as well.
Yes.
Okay. Okay.
Yeah, sure. Thank you then.
Okay, ma'am.
Bye.
See you. Take
Bye.
care. Good day.
Yeah. Bye.
Thank you, Simpson. Thank
Bye,
you,
ma'am.
students. Bye, everybody.
Yes, ma'am.
Bye.
Thank you, Chitra, ma'am.
Yeah, bye.
Bye, ma'am. Bye, ma'am. Thank you all.